Well, Dr. Maxwell, thanks for agreeing to speak to our academy, the American Academy of Craniofacial Pain, in October. So I want to start off just having you introduce yourself, a little bit of your background, and what it is you do on a day-to-day basis.
All right. Okay. Well, I'm Dr. Andrew Maxwell, and I'm a pediatric cardiologist. I trained at Johns Hopkins, UCSF, and finally Stanford. And I've set up my own private practice, which I've had now for over 20 years in the East Bay of San Francisco. And what I have noticed over the past decade or two is a certain population of patients that would be classified probably as complex care patients because they have so many things wrong with them, essentially. And to many doctors think they're just, falling apart in every way possible. There's a certain phenotype that these patients tend to have. And we ended up calling these patients the pentad patients because they have dysautonomia, mast cell activation syndrome, hypermobility, often full-blown what's called hypermobile Ehlers-Danlos syndrome, as well as very significant gastrointestinal issues and often autoimmunity. So those five entities that seem to come together. In working with these patients, it became clear that many of them, a subset of them, about 15% of the total population, had issues surrounding their craniofacial region. And that led to the discovery that most of these patients have Cranio-Cervical instability and they have an airway issue. And so much of the focus of our management and workup and treatment is correcting the Cranio-Cervical instability, re-establishing a good airway, and then recognizing some of the consequences that occur because of these two issues, loss of airway and Cranio-Cervical instability. And one of the big issues is the injury that occurs to the cranial nerves because of this instability, particularly cranial nerves 9, 10, and 11. But there's also a second phenomenon that occurs separate from the Cranio-Cervical instability, secondary to it, and that is these patients often develop fluctuating intracranial hypertension. And this is because of this phenomenon of this tied in, tied out of blood flow into the brain while asleep and while awake. So these patients, when they fall asleep, they retain carbon dioxide. Blood flow increases into their brain, their skull overnight, increasing intracranial pressure. And then when they wake up again, they breathe better. They actually hyperventilate. Their CO2 in their blood drops. Blood leaves their skull, and then they actually have a low pressure intracranial pressure situation in the daytime. So they go between high pressure at night, low pressure in the daytime. But this high pressure at night does many, many things, including causing headaches, high pressure headaches, but it also tends to cause this phenomenon not previously described. We're calling it Wardley phenomenon for Deborah Wardley, the co-author on the paper, who first described it previously. And that is this high intracranial pressure also involves pressure within the sleeves that all the cranial nerves are surrounded by. They all have sleeves. And so there's pressure that compresses all the cranial nerves, not just 9, 10, 11 is injured, but all the other cranial nerves. So that means the facial nerve and the trigeminal nerve are compressed. And so they're injured. And so we believe some of this facial pain and maybe occipital pain that's occurring is occurring because of this Wardley phenomenon through the increased intracranial pressure. And so it's our belief that correcting the Cranio-Cervical instability and correcting the airway corrects all of this.
That's fantastic. And, anybody seeing enough of these patients in that pentad, you just described a lot that come into our office. And as dentists, we can help with so much, but if we understand the broader implications, we can collaborate and communicate. In your experience over the years sharing this with your dental colleagues and orthodontists, I assume you've seen it to be very well received and a lot of head nods as you start talking.
That's exactly right. And everyone in the health field, whether it's dental field, airway field, otherwise, ENT, sleep doctors, immediately recognize these complex patients and say, this is now what I understand how they're so complex and how all these different symptoms fit together. And then I usually have people in the audience come up to me afterward and say, I think a family member of mine has this. And I think, even I might have this. And so it's really ringing true. And, we published our paper, the full theory, just a couple months ago. And we've been getting remarkable read rates as well as comments back that this is fitting. And another group in Wake Forest, neurosurgery group in Wake Forest, basically found the same population of patients. And they published on that very recently too.
And with your permission, we're sending that out to the attendees before. But real quickly, if you were to describe the spiky-leaky scenario, how do you describe those two parts, the spiky versus the leaky, and how you're quantifying that in the theory you described?
Right. Yeah. Well, I mean, the spike refers to the spike in the CSF pressure, and the leak refers to the fact that these patients end up with CSF leaks. And it all has to do with the tight in, tight out phenomenon. And it all goes back to, as I already mentioned, the loss of airway and the cranio-cervical instability. But as part of that, these patients are in sympathetic overdrive as part of their dysautonomia. They develop a sympathetic overdrive, which forces them to hyperventilate, forces their blood CO2 levels down, which basically clamps down blood vessels in the head. So they hardly have any blood flow during the day, which creates brain fog. It creates migraine headaches, and it creates dizziness upon standing and all. And then it's reversed at night when they lose their airway, and blood massively increases into the skull at night and spikes their CSF. They have a high pressure situation going on, but they usually hit a pop-off level at which there's a secondary pathway for CSF to drain from the skull. And that is through these cranial nerve cuffs. And one particular one that seems important, or at least we can visualize, is that it crosses the cribriform plate through the olfactory nerve into the sinus tissue and either is drained away by the olfactory lymphatics, or it overwhelms those as well and seeps into the sinuses themselves. And when the patient sits up in the morning, they actually gush CSF out their nose or down the back of their throat. And so we've seen this, we've tried to understand it, and this is the theory we've come up with.
That's amazing. And then one last thing you and I talked about previously, if you see children that are bedwetting related to jaw joint dysfunction, mouth breathing, kind of walk us through what you'll talk about in terms of the pathophysiology of that happening, relating to that distal pressure of the posterior displacement of the mandible inside the glenoid fossa and pushing on that plexus.
Yeah, well, I mean, one of those mechanisms is this concept of the Wardley phenomenon again, where if you increase intracranial pressure, you're also increasing that pressure up and down the spine. And so you also have dysfunction of sacral nerves as well, and loss of bladder control from what we would call pseudo-tethered cord. So tethered cord is where there's an actual tethering of the bottom of the spinal cord to the sacral bony material. And this doesn't necessarily have to be the case. Sometimes just the CSF pressure can create a tethered cord situation. And when you have that happen, you lose the sacral nerve control to the bladder, and you lose continence.
And then last question, what are you most excited about in terms of collaborating with the American Academy of Craniofacial Pain, and what you hope to gain out of spending some time with us?
Yeah, well, I mean, this theory is so complex, and it should speak to almost every specialty. Every subspecialty should be interested in this. And so it is my hope that those who hear this will both embrace it and challenge it. And so some of it will be with some disbelief, perhaps, and say, I want to go back and test this theory, and I want to go back and design studies to understand this better. And hopefully it'll take the theory further, and parts of this very, very complex theory will start to be tested and shown in literature.
Well, I'm happy and honored that you're joining us. Paper was just published in March, and to get to have you speak about, 6, 7 months after that, and get some feedback from colleagues that have read it, I think super excited to hear what we discuss, and then we're going to leave plenty of time for questions, as we know we'll anticipate those. So, Dr. Maxwell, thanks for joining us in October here, and look forward to seeing you in person.
Okay, thank you very much.